Thank you, chairpersons, senior colleagues, and my dear friends. The management of aortic valve disease has been drastically changed in the last 2 decades after the invention of transcatheter aortic valve replacement. So the main aim of this talk is to give an idea what is a transcatheter aortic valve replacement and which patient is ideal and how to choose between a surgical aortic valve replacement and a transcatheter. So when you see aortic stenosis, the most common cause is degenerative. It accounts for around 58.1%. The rest comes the bicuspid aortic valve, then a small proportion, less than 3% by rheumatic heart disease. So these patients of aortic stenosis are mostly of advanced age. So there's a strong correlation between the advancing age and the increased prevalence of severe aortic stenosis. When you see the prevalence of age more than 75 years, it's around 3.4%. And when the age goes above 80, it's almost touches 10%. And they have a very high mortality and morbidity. The 5-year mortality of a severe aortic stenosis patient managed conservatively is around 55%. That means almost more than half of the patients die within 5 years of diagnosing a severe symptomatic aortic stenosis. And the incidence of heart failure is around 17.5% if the ejection fraction is less. And even if it's normal, it's around 15.3%. So when you see this subset, they are mostly elderly patients with a lot of comorbidities, very high risk for surgical management. So many a times we were forced to manage them conservatively, which medical management has very less role in these patients. So they continue to have a poor quality of life, recurrent hospital admissions, and severe symptoms. So with this idea, something has to be done for such patients. The idea of transcatheter aortic valve replacement was put forward. Initially was done in animal models. Then the first transcatheter aortic valve replacement was done by Dr. Alan Crebier 23 years ago in 2002 on April 16th. It was a 57-year-old gentleman who was in cardiogenic shock, severe LV dysfunction, ejection fraction of 12%, and it was a successful procedure. He improved, but unfortunately died due to some non-cardiac cause. But at that time, the most reviewers thought that TAVR will never work. It's a stupid and unethical idea, and the surgery is good enough for all aortic stenosis patients. But now we know the rest is history. Today, TAVR is becoming the mainstream therapy, saving lives and improving the quality of life in high-risk and inoperable patients. More than 1 million cases done globally today. TAVR is also expanding into the low-risk and younger patients. So TAVR gave birth to the most impactful and path-breaking intervention in the history of structural heart interventions. So a small animated video of what is actually the TAVR, what we do. This is a balloon expandable valve where the valve is crimped over a deflated balloon, and the valve and the balloon is taken with the help of a catheter through the aorta, across the aortic valve. So it's now, we place the valve across the stenotic aortic valve and we inflate the balloon. So when the balloon gets inflated, the valve expands and it gets deployed and get attached to the native aortic valve. So here, this is the valve and the crimped over the balloon. Now the balloon expands. As the balloon expands, the valve expands and it gets attached to the aortic valve. And we take out the balloon and all. This is how it is being done. You have also a self-expanding valve where the valve expands by its own. Now, the first major trial for transcatheter aortic valve was the PARTNER 1 trial, which has 2 cohorts, cohort A and B. A was very high-risk patients where TAVR was compared with the surgical aortic valve replacement. They found that the TAVR was non-inferior to surgical aortic valve replacement. The cohort B was inoperable patients. So the TAVR was compared with the medical management, and they found that there was 46% mortality reduction in the TAVR arm. The other trial in high-risk group was the CoreValve high-risk study, where the TAVR and the surgical aortic valve replacement was compared and found to be superior to surgical aortic valve replacement in terms of all-cause mortality. So in high-risk and inoperable patients, definitely TAVR is favoring when compared to a surgical aortic valve replacement. So they thought, well, we'll try in intermediate risk. That means severe symptomatic aortic valve disease patient who is having an intermediate risk for a surgical aortic valve replacement. So the two trials were the PARTNER TRUE and the THRISSUR. Both showed a similar outcome when TAVR and surgical aortic valve replacement was compared in terms of death, disabling stroke at 2 years, and they were followed up for 5 years and also found to have the similar outcome. Again, they went for the low-risk cohort. The trials were major, the PARTNER 3 trial, where they found that it was in fact significantly lower, the TAVR was having a significantly lower incidence of death, stroke, and rehospitalization at 1 year. And EVOLUTE low-risk trial, where it was found to be non-inferior to surgical aortic valve replacement at 2 years. So the data is clear. Now you have data for high-risk, inoperable patients, which TAVR favors over surgical aortic valve replacement. In intermediate and low-risk patients, it's almost comparable with surgical aortic valve replacement. Now, when when the low-risk patients were enrolled for the TAVR, the durability or the long-term outcome is also very important, because once you enroll younger patients, how long will this valve last was a question mark. So there was a 10-year outcome trial for the NOTION trial. TAVR was compared with surgical aortic valve implantment, and they found that there was no significant difference in all-cause mortality between the two groups, stroke, also MI. TAVR had more permanent pacemaker implantation, but new onset atrial fibrillation was more in the surgical aortic valve replacement. The effective orifice area was larger for the TAVR patients with low transprosthetic gradient. More paravalvular leak was found in the TAVR. And when you see the structural valve deterioration, it was higher in surgical aortic valve replacement. And the rates of re-intervention was very low and not different between the two groups. So the long-term outcome data is also available. Now they have tried TAVR in asymptomatic severe AS patients with normal ejection fraction. Current guidelines for such patients, asymptomatic severe AS with a normal ejection fraction, is just clinical surveillance. They have tried this in the early TAVR trial, where they found that there's a 50% reduction of primary endpoints of death, stroke, and unplanned hospitalization at 2 years and 5 years with TAVR. 57% reduction in the unplanned hospitalization, 38% reduction in stroke. So even in an asymptomatic severe AS patient also, TAVR was having a positive outcome. We'll see what the guidelines has to say, the 2020 ACC/HA guidelines. They have given a class 1A indication for patients between 65 to 80 years with severe symptomatic aortic stenosis who can undergo a transfemoral TAVI or a surgical aortic valve replacement. Both is given a class 1A indication. So it can be taken as a shared decision which to be chosen. If the age is more than 80 years and the life expectancy is less than 10 years, and if there is no contraindication for a transfemoral TAVI, then it's a class 1A indication when compared to surgical aortic valve replacement. So our experience on TAVR, this was a 69-year-old male, hypertensive, COPD, mild renal dysfunction, recurrent hospital admission for acute heart failure. ECG was showing a sinus rhythm with incomplete RV, LVH. Echocardiogram showed a calcified aortic valve, severe aortic stenosis, good LV function. Cardiac CT was done, which showed a bicuspid aortic valve with a moderate calcification, a good-sized femoral arteries. So transfemoral TAVR was possible in this patient. So the images, the first one is we pre-dilate the valve with a balloon so that you can take this bulky valve across the stenosed aortic valve. So, and the second is the balloon expandable valve, where you can see the balloon, the valve is crimped out of the balloon and the balloon expands and the valve expands and it's get deployed. He is on follow-up for the last 1 year and 9 months and asymptomatic, normal aortic valve gradient, no paravalvular leak, normal renal function, and on low-dose aspirin and statins. Now, is TAVR possible in aortic regurgitation? There are some difficulties when you try TAVR in aortic regurgitation, because in TAVR, we don't have a suture to hold the valve at the position. So it's the annular calcification of the native valve which holds the valve at that position. So in aortic regurgitation, there's lack of annular calcification, so it is harder to anchor the valve securely. And these patients usually have a very large aortic annulus when compared with the AIS. So a proper sizing and sealing is always a challenge. So we have specialized valves with anchoring mechanism like GINA valve, which can be used in severe aortic regurgitation patients. But even the normal TAVR valve is being used off-label in many aortic regurgitation patients with good results. So how to choose between TAVR and surgical aortic valve replacement severe AS? First thing has to be decided is whether the patient needs a mechanical or a tissue valve. So if it's a young patient, yes, less than 50 years, definitely he needs a mechanical valve because it has the most longer durability. Now, if the age is more than 65 years, then you can go with the tissue valve. If the age is between 50 and 65 years, it's a shared decision whether to choose for a mechanical or a tissue valve. Now, if you have chosen a tissue valve, there are two options, either surgical or a transcatheter. So if its age is less than 65, you can go for a surgical aortic valve replacement. If it's more than 80 years, it's a class 1 indication for a transcatheter aortic valve replacement. Now, between 65 to 85 years, it's a shared decision, where some of the points which favors is TAVR if the transfemoral access is possible. If the surgical risk is high, TAVR favors, though you have data for the low risk and intermediate risk patients. Aortic annulus, if it's very small or a very large aortic annulus of more than 35 mm, surgical aortic valve replacement will be better. A risk of coronary ostium obstruction, though you have, should be careful when you try for a TAVR, it's not a strong contraindication. So take-home message, it's one of the major path-breaking interventions in the field of cardiology. It's a game changer in inoperable and high-risk severe AS patients. And it's having similar immediate and long-term outcome even in intermediate and low-risk patients. Thank you.
An excellent talk, Kiran. So it's a fantastic journey of TAVR. It started off with those patients who had a prohibitive surgical risk. Something like a palliation, the life expectancy is limited. He cannot undergo a surgery, and surgery was the gold standard. And then the journey take a different course. Then it became equivalent to that of surgical aortic valve replacement in elderly patients. And with the current guidelines, it is clear, 80 plus, TAVR is preferred over SAVR. 65 to 80, it's a shared decision making. And less than 65, younger patients with longer life expectancy, our longest data is up to 10 years, 9 years to be precise. So that's why younger patients, mechanical valve, long durability, it's proven. We have seen patients or we have data up to 30, 35 years, long-term durability of the valve. But this newer therapy is coming up because the patients, now what Westerners are going to look at is, or they are trying to do is, do the TAVR, extubate, send him home on the same day or the next day. And you know the difficulties of sternotomy, elderly patient. Most of these patients are elderly patients, that is above the age of 65. They come to do the sternotomy, they have to go through the surgical, the problems of the surgery, the problems of the sternotomy, 3 months. It take at least 3 months for them to get back to the normal activity. This is easy. They'll come 1 day prior to the procedure, get the procedure done. Second day, third day, they are out walking and back to the normal life. Just like a PTC, isn't it, Kiran?
Yes.
It's a fantastic thing, but may not be for all. But it was like not for all 5 years ago. Now it's for most, isn't it?
Yes.
Am I right or wrong?
Definitely.
Now it's for most. There are certain situations where we may prefer a surgical aortic valve replacement. And the only problem in India is, who wants to undergo the difficulties of surgery? Nobody wants, especially 80 plus. Most of the 80 plus patients, they don't want anything at all. The problem is the cost of therapy. What is the cost of therapy?
The cost, it's actually drastically reduced. Initially, it was around 25 lakhs. Now you can do it at around 13 lakhs. But I think still it is going to reduce with the more companies coming with newer valves and the competition going up. Cost will come down, definitely it will come down.
As the uptake of therapy is coming up, more and more patients are undergoing the procedure. There are a lot of players in the field. So natural, and a lot of Indian valves have come up with good data, so the cost will come down. It was 25, now with the imported West valves, it is 20. And with the Indian valve, whose data is equivalent to that of the imported valves regarding the efficacy and the safety, we can do it at 12 lakhs. But a surgical aortic valve replacement can be done at 3.5 lakhs.
Now that's the difference.
That's a problem. That's a problem. So those patients who can afford, who have comorbidities, who prefers, this is the treatment of choice. Any, you want to add something? And any questions from the audience? We can.
The ESI, ECHS scheme covered for this thing?
I'm not sure, sir.
Not sure.
Thank you, an excellent talk. I think this puts into perspective really TAVR in how we should consider. And, you know, for younger people, when we were students, Dr. Jabir would remember, there's hardly any sclerotic aortic stenosis or age-related. It would be all rheumatic. So any valve disease, reflexively you think of rheumatic. And how drastically in the last 20 years things have changed. Today you must have seen that many of our patients who come with severe aortic stenosis, degenerative, are women, small frame women. We didn't have such patients 20 years back. So the whole aortic stenosis field has changed. So what is driving it? Two new things have come in. For example, one for the people who practice medicine. One is the LP little a. You know, there's something called LP little a, which was part of the lipid profile. Today we know that LP little a high indicates that they are at a fast track for going into sclerotic aortic valve disease and severe aortic stenosis. Many women have them, number one. Second, if a lady has a pregnancy-related hypertension, they are at a 5 times higher risk of developing aortic valve disease, which we didn't know. So probably the whole arena has changed. Today we see so many people coming with atypical chest pains, this, that and all that. When we put the stethoscope, okay, my God, there is severe aortic stenosis. And what do we offer? And many of these elderly or so-called, elderly, borderline elderly women would straight away refuse an open heart surgery. Doctor, surgery, what is this? So I think TAVR is coming in a big way. And the way all of us look at it would be in the next 10 years. Probably we would be offering TAVR as a therapy for everyone and tell them that maybe you can consider surgical because you have this following risk factors. Thank you. It was an excellent eye-opening talk. Thank you.
I have a doubt. We have reached up to aortic valve, transfemoral load. Can we reach up to mitral valve in the later period, like in 1 decade or 2 decades?
No, it's been done. It's been done. Transcatheter mitral valve replacement is possible. And even for mitral regurgitation, you have mitral clips. So there are a lot of newer things which I think all the valves are now is possible with the transcatheter route.
We cross the septum. We cross the interatrial septum and goes through the mitral valve. There are certain valves which can be implanted, especially in a degenerative previous bioprosthetic valves in the mitral position. And as he said, for mitral regurgitation, we have clips, which clips the mitral valve and reduces the regurgitation. So the medicine is changing. These changes are basically due to the great treatment we are giving for most of the other cardiac diseases. So the age increases, people live more. And as the people live more, the epidemiology changes. Now we are seeing more, as sir was telling, Tiny sir was telling, more of degenerative aortic valve disease, less of rheumatic heart disease, more of heart failure, more of atrial fibrillation. And these are the 3 areas where extensive research is going on. This is because of the aging population we are dealing with. Thank you so much. I think we can close down the session with a good hand.